before we'll take a little bit of a break for lunch.
Some of our presenters will not be able to stay with us all day for the putting it together session. So if you do have questions for some of these earlier presenters, like Dr. Verton or Dan, asking those ahead of time. While we kind of transition, it looks like maybe we need like just 5 minutes for a bathroom. Is that right? Okay. So let's take 5 minutes for a bathroom and we'll transition to our next speaker then. Oh, okay. Look at this, super quiet.
I didn't have a lot. I mean, it's not much more right, but I have my own.
Well, it brought up the best one. I guess you are. Yeah. I can't wait for the band. You guys
have 2 more.
That we do have a table. And I did more. It's always
What do you do? Well.
Okay, does everybody seem like most of their table mates are back? All right. Well, we are going to go ahead and get started with the next portion here. So I have Kevin Sponsel here with me. Kevin completed his Doctor of Pharmacy degree from Mercer College of Pharmacy in Atlanta, Georgia, after which he completed a PGY-1 pharmacy practice residency at Emory Healthcare in Atlanta, Georgia, followed by a PGY-2 specialty residency in infectious disease in Franciscan St. Francis, is that right? Franciscan St. Francis Hospital in Indianapolis, Indiana. He is currently the infectious disease pharmacist at Bryan Health in Lincoln, here at this hospital, where he co-directs the antimicrobial stewardship program. So we are very excited that Kevin was able to speak today. He has a wealth of knowledge, has been very important in our sepsis treatment and evaluation here at the organization. So he is definitely a good go-to person with any antibiotic questions that you might have. So thank you, Kevin.
Thank you. Thanks. She also forgot to mention that I have a little 2-year-old at home and a 5-week-old at home. So if I seem to be dragging a little bit, I apologize. Or hoarse from coaxing my 2-year-old back to sleep all night. So I thought what we'd do is talk a little bit about antibiotics from a 50,000-foot view, really highlight the important things as it relates to surviving sepsis campaign guidelines, touch on what CMS has to say about that, because you can't really ignore that in a lot of settings, and then really give you a survey of a lot of antibiotic topics, and then open it up more for questions rather than drive too deep on any one specific point. So if you have questions throughout this, please just interrupt and ask them. So here's some abbreviations. Again, if you have any questions further, I can address those. So our objectives are going to discuss antimicrobial therapy concepts. We're going to review exactly what the Surviving Sepsis Campaign guidelines say about antimicrobials specifically, acknowledging that source control is paramount. Identification of source is key here, but we're not going to really touch on that too much. We're going to demonstrate the impact of time to appropriate antibiotics. Why are these recommendations what they are? We'll discuss appropriate antibiotic selection based on source. How do we figure out what the right antibiotic is based on source or unknown source potentially? We'll review some dosing considerations in sepsis, because again, Surviving Sepsis guidelines make some recommendations. Then we're going to talk a little bit about how do you balance the perceived need to give broad spectrum antibiotics to a very large cohort of patients who screen sepsis positive, but still do antimicrobial stewardship, something we try to balance every day. And then discuss a little bit of the logistical hurdles that you might encounter in a hospital, acknowledging that I probably won't be able to touch on all the ones that you guys might experience in some of these critical access places, because we do have a little more resources here. And then some of the compliance hurdles, balancing CMS measures with actual good clinical practice. So out of the gate, really the most important thing to know is what are the likely pathogens causing any particular infectious syndrome. Those are going to be what informs how you pick your antibiotic regimen for severe sepsis or septic shock. Early and appropriate antimicrobial therapy is essential, really no matter what you're treating, whether it's sepsis syndrome or it's just an infection. It should always be broad enough to cover all likely pathogens with a goal to narrow or de-escalate within the next 48 to 72 hours. And it should have a favorable pharmacokinetic or PK profile to make sure that you're dosing the drug appropriately for the source, the site, the pathogen, whether you have some elevated resistance in your community or not. And keeping in mind that in the septic patient, you're using a lot of vasopressors, you're giving a lot of fluids. The pharmacokinetics or how the drug moves in the body can change very rapidly. So antibiotic selection can seem quite nebulous a topic and potentially even esoteric at times. So I like to break it down into domains of how I approach it. So the optimal antibiotic really has to consider host factors, antibiotic-specific factors, so that's the pharmacokinetics, how does the drug work, is it bactericidal, bacteriostatic, time-dependent, concentration-dependent, et cetera. What am I trying to treat? It's different if I'm treating a meningitis versus a UTI. How much antibiotic gets into the brain versus the urinary tract. Pathogen-specific factors. Is there intrinsic resistance based on the organism that's likely to cause that infection or not, or is it kind of run-of-the-mill E. coli, et cetera? And then adverse drug events from the drug itself. Each of these domains then has more specific sort of factors to consider. I won't list each one of these, but you can see kind of dive deeper and deeper and deeper at each branch of this selection process. So thinking about that, that's kind of the backdrop to how we approach stuff. Now we have to harmonize this sort of theoretical understanding of how do I pick the right antibiotic in a given generic scenario with what do the surviving sepsis guidelines say that we should be approaching sepsis. How should we approach it in regards to antimicrobials? And so we'll address each one of these and kind of talk about them and why they're a recommendation. So the first one is that administration of IV antibiotics should be started as soon as possible for both sepsis and septic shock. Now recognize we're using sepsis 3 definitions here, slightly changing the paradigm of how we triage and organize sepsis versus CMS is still using sepsis 2 definitions of sepsis, severe sepsis, septic shock. Basically in the new paradigm, maybe we already talked about this, I missed the first part of the meeting, they've taken severe sepsis and sort of lumped it into the septic shock category. The second one here is that empiric broad-spectrum therapy with one or more antimicrobials should be started to cover likely pathogens for all those with sepsis or septic shock. So now, these 2 recommendations basically say start within 1 hour for best clinical practice and start appropriately broad antimicrobials, either using single or double agent. And where we get that data from is this study by Kumar and colleagues. So this data is back from 2006. But this is really the study that keeps getting cited over and over again that prompts us to start antibiotics in sepsis within that first hour. And what they demonstrated was for every hour delay of appropriate antimicrobial therapy, you had an increased mortality by about 7 to 8%. So if you hear that statistic cited, this is the study where it's coming from. And this is really underpins CMS's recommendations from the Surviving Sepsis Campaign and guideline recommendations. Now the difference is in the previous iteration of those Surviving Sepsis Campaign guidelines, they recommended this recommendation a little softer. They say if you can 1 hour, and now it's a full-blown official recommendation. CMS still says 3 hours is the time to appropriate antibiotic. The recognized best clinical practice is that the sooner the better. Within an hour, there is clinical data to support saving lives. Further, it's been repeatedly demonstrated that over and over that the right antibiotic or appropriate antibiotic saves lives. So on your y-axis here, you have various studies in either ventilator-associated pneumonia or sepsis, and on the x-axis you have a percent mortality. And each of these bars for each of these studies represents patients in blue who received appropriate initial antimicrobial therapy, defined as having in vitro activity in culture-positive settings. And in the red bars are those who received inappropriate initial antimicrobial therapy. So an example would be a patient comes in with Pseudomonas pneumonia, bacteremia, and you started ceftriaxone. Right? That's a drug mismatch. That's inappropriate initial therapy. In that setting, in the red bars, you can see mortality is consistently higher across decades and across studies in these patients with VAP or sepsis. So the next step to figuring out how do I attack this, how do I start to block and tackle taking an antibiotic and knowing whether or not ceftriaxone is the right drug for any particular syndrome or setting. So you start to break it out by source, and this is one of the recommendations also in the Surviving Sepsis Campaign guidelines. And these are how we've done it on the left side of the screen here for our sepsis management order set. And on the right there's just the IDSA guidelines. And so the starting place for us is an evidence-based approach. We take guidelines, we say, what do the guidelines say are the likely pathogens for lower respiratory tract infection, UTIs, intra-abdominal, skin soft tissue, CNS, et cetera, unknown, and then in the case of immunosuppression or neutropenia. And then we take our own local microbiology data, and then we start to filter and get narrow and narrow. So where the IDSA guidelines might offer that somebody should come in and be started on cefepime for suspected pseudomonal pneumonia. We say, well, maybe Zosyn for us is more active up front. So if Zosyn is going to cover more of my pseudomonal isolates, that's going to be my primary therapy locally, rather than relying on the guidelines who say pick one of cefepime, Zosyn, or meropenem, or something else. That's how we start to narrow our focus there for selection. So the next thing they say is that you should, once you have a pathogen, you should be aggressively de-escalating and narrowing your antimicrobial therapies. So we'll start to talk about the antimicrobial stewardship part for this third recommendation. They recommend against using antibiotics for syndromes that are explicitly not infectious related. And the classic example that I see most often is severe acute pancreatitis, which is 99.9% of the time non-infectious, and using antibiotics in that setting to prophylax against an infection has been shown to be associated with increased poor outcomes, particularly antimicrobial resistance, colonization with C. diff, VRE, and have no benefit towards improving outcomes. And so this is where reassessing that initial diagnosis of sepsis, if we're going to be very aggressive using broad spectrum antimicrobials up front with a higher suspicion, so that we don't miss anybody, that we need to be reassessing the diagnosis and ruling in or ruling out sepsis 48 to 72 hours in. And then they further recommend that we use PKPD to dose optimize antimicrobials based on patient-specific factors, bug-specific factors, and the syndrome-specific factors. And the next few slides, we're going to talk a little bit about how we tackle that, because one of my kind of bugaboos is the FDA package insert dosing for a lot of antimicrobials is very often substandard. And it's nice to see that guidelines are starting to really recommend that we take a patient-specific and a pathogen-specific approach. So the dosing and the MIC matters here, and there's numerous publications that demonstrate that increased treatment failure and mortality has been associated with organisms that have elevated MICs. That's the minimum inhibitory concentration, so this will be the number you get on a micro report. Suboptimal pharmacodynamic target attainment, so when we measure blood levels of our cefepime in a patient population, for example, we find out that it's lower than we would have predicted it to be if we're dosing it based on FDA package insert dosing. And then even intermittent versus prolonged infusion, we're going to talk about why dosing strategy matters and how this all kind of fits together and stacks together. And a really good example of this in practice is this point prevalence study called the Defining Antibiotic Levels in Intensive Care Units, or the DOLLY study. They did a point prevalence study worldwide, hundreds of different ICUs, where they took patients with infections on beta-lactams and they measured their blood levels of that drug, and then they evaluated what's the likelihood this is going to achieve the appropriate pharmacodynamic target. And they found that at least in a third of these patients, again, this was one point in time, one day, but they found a third of the patients were being suboptimally dosed on these antibiotics. And they did find that in those patients suboptimally dosed, treatment failure was higher in those patients compared to patients who were dosed better, more appropriately. So here, and laying the foundation here, so if anybody wants to know why are we doing the things we do, why do the surviving sepsis guidelines say what they say, why does CMS say what they say, why do we have to manage sepsis in this big protocolized way, why does it have to be so multimodal and everyone be so regimented and attack it like we do other things, and that's because these outcomes are time sensitive, there's a ton of minutia along the way, and we have to get every single piece right within a certain amount of time to get the outcome we want to see, to get the positive results. And so just laying the groundwork for that it is important, that it isn't just governmental regulatory bodies saying, do it this way because I want us all to feel confident we're doing the right clinical thing. So we will dive into the weeds just a little bit here. So this study by Batt and colleagues looked at cefepime MICs on the x-axis here, and then your 28-day mortality on the y-axis. They were specifically looking at was patients with pseudomonal bacteremia who received cefepime, and then they stratified mortality outcomes by the MIC of that organism. And so, as you can see, as you go from low on the left to higher, so from 1 to 2 to 4, and then you jump up in mortality based on the bars here, from 4 to 8, as those organisms have higher MIC, which means they're slightly more resistant to cefepime, mortality increases. Okay? So the implicit understanding here is that for any fixed dose of cefepime in this study, the higher the MIC was, the less effective that drug was going to be. And then Perry Bauer and colleagues took it a little further, and so they did a study, and then they also evaluated the pharmacokinetics and the dosing strategy. And they said, well, I know that if I give beta-lactams as a prolonged infusion, I'm able to achieve my pharmacodynamic targets easier. Maybe there's a difference, and I know if I have elevated MICs, that's higher mortality, maybe there's a difference between how I'm dosing it. Maybe I need to give bigger doses, or give it as a prolonged infusion, or give it more frequently. What is the problem here? And what they did with Pseudomonal bacteremia again was they evaluated mortality based on the infusion strategy of cefepime. And in this study, they were using either 1 gram or 2 grams Q12 per package insert dosing. And they found that those folks who got standard dosing over 30 minutes of cefepime for this particular setting had a 20% mortality compared to 3% mortality for folks getting a prolonged infusion. So really powerful stuff here to demonstrate that like how you dose matters. Whether you have a more resistant population, bacteria in the community matters. And we can potentially tackle it with how we give the antibiotics. And this is just some background. This is the underpinning for why that makes a difference using a short bolus infusion or a prolonged infusion. So beta-lactams are a time-dependent antibiotic, which means the longer that you have concentrations in the blood above the MIC of the organism, the more effective that antibiotic is, the faster it's going to kill the bacteria. And what you have here is the concentration versus time curve. And this is what a lot of us nerdy pharmacists are thinking about constantly, at least I am. And on your x-axis, you have time in hours, on the y, concentration. And so you give a dose of this drug, and it goes up to a peak, and then it's slowly eliminated over time. And that dashed line is the MIC of the organism. And so for, we're going to use in this example, 50% free time of MIC is our goal. So this would result in optimal bactericidal activity if my organism had an MIC of 2 in the cell. But you can see that if I elevate that MIC, so like in the study, if the MIC is 8, now I've reduced the time, the free time of MIC for this drug, down to 25%. So in essence, I've cut the effectiveness of this drug in half by virtue of just having a bug that has a higher MIC. So some of the ways we can tackle this, or you could give a bigger dose of the drug, so instead of giving 1 gram, I give 2, but you can see that it only buys you a little bit extra time. I can give it more frequently and re-achieve my 50% free time of MIC here. So the same as if my MIC was 2. Or, and now again, this is doubling the amount of drug I'm using in the same 24-hour time period. Or more efficiently, I can give it as a prolonged infusion, use the same dose of drug, the same dosing interval, and re-attain my 50% free time with MIC. And so this is one of the strategies that we are attempting to employ more and more, is use more prolonged infusions to dose optimize to that contingency where you might have a certain, maybe it's 10%, 20%, whatever, of your susceptible populations of bacteria that are, have elevated MICs, just barely susceptible, basically. And this is some more formalized pharmacokinetics to sort of demonstrate these principles and how, and I'm also just trying to get us to how do we pick a dose, right? Now we've talked about how do I pick a drug, how do I narrow down and know what's the right drug for a particular syndrome and source. Now how do I pick a dose of cefepime, right? It's not just enough to say, oh, cefepime is the right thing for patients coming in with UTIs, with catheters in my institution. Now I gotta know, am I dosing it appropriately? So this is how we get there. This is a probability of target attainment curve. What this is you have different doses at different infusion strategies, represented by different lines here. So a solid line with a darkened circle, dashed line with an open circle, etc. And at different infusion strategies and doses. And you can see it's 1 gram Q12 is a 30-minute, 2 grams Q12 is 30-minute, 2 grams Q8 is a 30-minute, and 2 grams Q8 is a 3-hour infusion. And what you have is the MICs plotted on the x-axis, and then on the y-axis, the probability or percent likelihood that if I give that dose, I'm going to achieve a good outcome, my goal pharmacodynamic parameter. So in this setting, if my MIC is 1, I can essentially give any dose of cefepime and feel confident that I'm going to get my free time above MIC where I need to be to get a good positive clinical outcome. But as that MIC increases, you see that now I have to start using higher doses or increased frequencies. As it goes to 4, you can see now even the 2 grams Q12 is not going to cut it, so I have to be dosing at least Q8 to achieve the same pharmacodynamic target for an elevated MIC. And if my MIC is 8, which happens to be the susceptibility breakpoint for Pseudomonas, I have to at least be using a 2 gram Q8 as a 3-hour infusion to achieve my goal pharmacodynamic targets and still get a good outcome. And that still doesn't even get me to 90% likelihood that's going to cut it for most of my patients. And so what we did was we took all that information and knowledge and we said, okay, so now how do I know if 2 grams Q8 is a 3-hour infusion, or 2 grams Q8 is a 4-hour infusion, or 1 gram Q8, et cetera, is the right thing to do? Do I even need to do it? And so what we did is we plotted our MIC distributions, and so this is a graph of pseudomonal isolates from now 2 years ago. On the x-axis is a frequency histogram of each of the individual MICs, and so you read this as 37% of our Pseudomonas isolates had an MIC of 1, 38% had an MIC of 2, et cetera, et cetera. And what we did then was we said, what percent of our isolates in total, if I just know that somebody has Pseudomonas sepsis, right? How many of what's the percent likelihood that that organism has an MIC of 8, 4, 2? And so we know that 97% of our isolates have an MIC of 8 or less, and 85% have an MIC of 4 or less. And so what we currently do, or what we historically have done, is we dose cefepime as a standard. If you order it here, you get it as a 30-minute infusion. We know that that has a very low likelihood of adequately treating somebody with an MIC of 8. And so that's basically 12% of patients with Pseudomonas infection where we could potentially be underdosing them, instantiating that practice. And so what we've done is we said, initially, we said, we're going to define how we define susceptibility for this organism so that providers know only 85% of these isolates are truly susceptible using standard dosing cefepime. And in phase 2, we standardize cefepime prolonged infusion. So that now, when you order cefepime, we do feel confident that's going to cover 97% of our Pseudomonas isolates. And that's just what's represented here. And so this is just an example of how now we've taken this approach and try to be more patient-specific or population-specific and organism and syndrome-specific with our dosing for antibiotics to really upfront make sure we're treating the sickest patients that might have the highest possible MIC for a susceptible organism and tackle it that way. And now this does put the burden on us to really aggressively de-escalate on the back end. But this is how we're sort of tackling each one of those tenets from the guidelines. So then moving back to the remaining of these surviving sepsis recommendations, they suggest that combination therapy should be used for septic shock only. And the classic example here would be using combination therapy of double coverage for gram-negatives or Pseudomonas. And really they say the only place that they recommend using it is septic shock. They say that they don't recommend using it for basically any other infection or for just sepsis. They also recommend against combination therapy for neutropenia or just bacteremia in the absence of shock. I'll tell you, I take a little bit of issue with this. I don't know if that's totally universal, but nonetheless, that's what they say. And then they do say that if you're using combination therapy, you should be aggressively de-escalating. It should be really in the first 24 to 48 hours because the benefit is really associated by broadening or truly double covering the number of organisms you're covering. And then much more difficult to prove, but synergy. So there's a potential to getting some benefit there. Regarding duration of therapy, they basically say that 7 to 10 days is appropriate for most infections, whether you have sepsis or septic shock, which I think I've always loved this aspect of the guidelines because even while the outdated CAP guidelines or intra-abdominal guidelines or what have you might say treat for an exorbitantly long period of time independent of severity of illness, the surviving sepsis guidelines have said no, the sickest you can possibly be, you can still treat for 7 days independent of source, and most patients get better most of the time. So it's really been a good advocate for shorter durations, more aggressive dosing of antibiotics up front, but really more aggressive de-escalation in shorter durations, whether they've explicitly marketed it that way or not. They really suggest that the longer courses be reserved for patients who are slow to recover, so not instantiating and standardizing, just treating somebody who's got septic shock the entirety of the duration of stay, but only those patients who are failing to improve. They even say that you can even use shorter durations of therapy potentially for infectious syndromes that have very readily sterilizable sources of infection. So they cite intra-abdominal and UTI. And again, this is mostly because you have source control achieved chemically with the antibiotic very, very rapidly. Most situations, you're dumping more than the serum concentrations into the bladder or the urinary system when you dose a beta-lactam. So these are, again, sources where you have rapid source control, but they're saying you can potentially treat for shorter. I would say that you still want to be guideline consistent and concordant. So if the UTI guidelines or CAP guidelines say treat for this duration, you want to make sure you're cross-referencing and not sort of going solely on this guideline to treat for 5 days for some particular syndrome. But nonetheless, daily assessment for de-escalation, again, promoting stewardship. They support that you can use procalcitonin to help decide whether or not to discontinue antimicrobials. Again, I think we've not instituted this as a standard protocolized policy because my own reading in the literature is that there are a lot of holes in the use of procalcitonin as a standard protocolized approach. It really does require a very patient-specific, nuanced understanding since there's so many reasons it can cause false positives or false negatives. That it's not something that's very easily just sort of set and forget as a panacea for whether there's a bacterial infection or not. Again, further recommendations, you can use it to sort of help rule out sepsis. I would again say this is a arrow in the quiver, not a panacea for diagnosing sepsis or not. It is a clinical diagnosis predominantly with some objective criteria. There's a fly there. And so procalcitonin can help you rule it in or rule it out, but it should always be done on a patient-specific basis. Any questions thus far? Okay. So how we really attempted to reconcile this need to provide broad-spectrum therapy up front, deal with the CMS pressures, deal with the clinical pressures that I have to get broad-spectrum, appropriate broad-spectrum therapy in a patient, diagnosed in a patient in an hour. That is a really, really tough task for anybody to achieve. And so some of the ways we've tried to tackle that is really focus on the upfront and the back end. And as much as we can sort of have the front end and the back end plans matching up is really what we've attempted to achieve here. And what I mean by that is we use evidence-based guidelines for those recommendations. We organize our sepsis order set by source so that physicians can find it easily. So if they're suspecting pneumonia or UTI or intra-abdominal, they can go click to it, and then it gives them a few options underneath each one of those rather than having to pick from all the antibiotics and all the potential doses that we might have on formulary in a big pick list. We use that local susceptibility data, right? So now I'm not guessing about whether or not cefepime-zosyn or meropenem is the right drug if I suspect Pseudomonas, infection and sepsis. Now I know it's zosyn, cefepime, meropenem, in that order for us. And then we create hierarchical antibiotic recommendations within each one of those suggestions to make sure that we're giving the patient the best chance for a bug that we know is going to give us the best coverage, our ability to dose optimize the best, and then also has the lowest potential to cause collateral damage on the back end. And then we are dose optimizing wherever possible to make sure that we pick the right drug, we got it to them in the right time, but now I'm also giving it, using the right dosing strategy to make sure that I'm catching that extra 12% who might otherwise have been underdosed in that 7. And some of the ways we've approached, you might ask, well, how do you pick beyond just cefepime, zosyn, or meropenem or whatever? How do you pick if you don't know your individual susceptibilities, or how do I know what's got high potential to cause collateral damage or not? And so the way we have approached it is based on a literature review to inform this, is we pick broad-spectrum antimicrobials that give us the best chance to cover the likely pathogens for any syndrome. That's the highest priority. And then the agents that we can dose optimize already as a standard. That's the top priority, is effectiveness up front. Then we've basically de-emphasized fluoroquinolones in every possible order set and official way that we can, basically because they are one of the leading antibiotic classes causing antimicrobial collateral damage. So if you can think of an acronym that you don't want to see at your institution, fluoroquinolones are one of the most potent instigators for those. So C. diff for CDI, VRE, MRSA, ESBLs, CREs, which are increasing in Nebraska, by the way. These things are potent stimulators for each one of those individually, more so than other antibiotic classes. They also have really deficient pharmacokinetics and pharmacodynamics. And so I won't bore you with the math here, but you would have to give something on the order of 2 grams of ciprofloxacin to actually treat your patient and achieve the concentration to MIC ratio that you actually should be achieving to get bactericidal activity. So when you're giving folks Cipro at doses less than that, not that I'm advocating doing that at all, please do not do that. One of the reasons we just don't use them as much as possible, you're basically tickling a lot of bugs into resistance rather than actually treating an infection in a lot of scenarios. So, and then the FDA has also released a new warning basically advocating not using fluoroquinolones more based on acute adverse events. So hyperglycemia, altered mentation, which is basically any patient that comes to the hospital. In our place, it seems to be 60 plus with polypharmacy. So adding fluoroquinolone on top of that is not generally helpful. So fluoroquinolone's largely bad if you take nothing else away from this. And beta-lactam is really given primacy in all our regimens due to their proven efficacy, bactericidal activity, and overall lower collateral damage profile. And then within the beta-lactam class, we even put a hierarchy there. So we always attempt to instantiate a penicillin-based regimen over a cefepime or a cephalosporin-based regimen over a carbapenem, and then over a monobactam, which is aztreonam, because each class has an increased potential to cause collateral damage. So penicillins, for example, actually decrease C. diff sporulation and actually have activity against enterococci, so your rates of C. diff and VRE are lower using penicillin-based regimens compared to cephalosporins. And quinolones are on the far end of this, the right side of this. And then carbapenems are right up there with your quinolones. So we really try to use as much of this strategy as possible, and still making sure that we're treating patients effectively for sepsis, so that we don't get ourselves into hot water on the back end. We just lit everyone up with a carbapenem who came through the door. Yeah, we'd cover them probably for the first couple years, and then after that, we'd have nothing left. You know, so this is how we've approached it. And we've taken away fluoroquinolones in a lot of places, and where we need double coverage, and replaced that with aminoglycosides. And I think aminoglycosides have gotten a terribly bad rap over the years. I am a huge proponent of their use in the appropriate context and with the appropriate monitoring. And so we've added them because they do broaden our coverage for most of our organisms. So if we have somebody with septic shock, this becomes very important. They do have a ton of data, largely in vitro for synergy, which means you kill more of the bacteria faster. But that first 24 to 48 hours is really the most critical time where the bacterial burden is at its highest, and the patient is at its most immunocompromised state. The bacteria are sort of winning that battle. And so anything we can do to more quickly turn the tide so that we decrease that bacterial burden is likely to result in improved outcomes. And there is good clinical data for using it in the septic shock patients and the neutropenia patients, that combination therapy is associated with decreased mortality. The thing that has always offset the utility of aminoglycosides in these large clinical studies is that they do composite endpoints. So yeah, patients had lower mortality, but man, they had higher rates of AKI compared to folks who didn't get aminoglycoside. And my bias on this is that nobody dies from AKI, they die with it. So if the sepsis is the thing causing the AKI, treating sepsis is going to resolve the AKI. So that's kind of the reason that we use a lot of aminoglycosides and why I'm not as scared of them as some other places might be. That being said, we do extended interval dosing, high dose, and we limit our duration of therapy to 48 hours max. And so we have automatic stops in there. We have pharmacy managed protocols where we do therapeutic drug monitoring. So most patients who come with sepsis or septic shock or anything on the continuum are going to get 1 or 2 doses of aminoglycoside. And by that point, we should either know that it is or is not sepsis. And we should know what pathogen is causing it or not causing it. But the role for aminoglycoside beyond 48 hours is extremely limited. And I'll also offer that rates of AKI in the literature are 0 to 5% with short course therapy compared to long course therapy, which is traditionally 7 to 21 days. And short course has been defined as 5 to 7 days. So they're not as scary if you use them appropriately and in short bursts. And so that's how we attempt to do instantiate that practice here. And again, now we got to do the work. We've done all that upfront work, and we sort of protocolize that. We have the order set in place. We have the protocols in place for the dosing for all these things. And now the work comes on the back end to make sure that we're readdressing that diagnosis. We're following up on cultures and making sure we can narrow therapy. If I can peel off an aminoglycoside a day early, we're doing that. I have a susceptible organism. And so that's really how we approach it, is then we'll review our patients. And a lot of this is sort of delegated to pharmacy staff or myself doing prospective audit and review. But even if it's just to bug the provider to say, hey, we take another look and we address the need for American, we're on day 4. And this looks like pancreatitis. Is it really an infection or not? Can we stop antibiotics and observe? We use procalcitonin really on a case-by-case basis, again, because of some of the limitations I discussed. It does have some utility, but again, more narrowly in patient-by-patient. And then if you're utilizing evidence-based durations of therapy, you're doing a lot of stewardship already, because we're moving more and more closer to short durations. So most guidelines are recommending 5 days of therapy, 7 days of therapy for most routine infections. And more data is coming out for different infections that we can potentially be using shorter. But if we can already just plan on confirmed pneumonia with sepsis, septic shock and Pseudomonas, you got them on the right drug and dose. Now let's just get a duration in there. Let's just put 7 days and call it good, right? Instead of leaving it open-ended, and then the weekend comes up, and then et cetera, et cetera. A couple other things just to readdress. So I kind of touched on it, but the regulatory issues. The 2 antibiotic-related measures for CMS are time to antibiotic and appropriate antibiotic. Time to antibiotic, the difference is clinically we shoot for 1 hour. CMS says 3 hours. And then the actual appropriate antibiotic, this is a bit where we have some regulatory bodies mucking about and making decisions that aren't totally aligned with clinical practice. They have 2 tables. They have table 5.0 in the SEP1 measure and 5.1. Each of these defines either appropriate broad spectrum monotherapy or an agent that needs to be used in combination therapy. And so what we've done with this is, the example for us is in cellulitis. Clinically, based on the syndrome, if you're a non-purulent cellulitis, even if you have septic shock, that's still very much most likely a beta-hemolytic strep. And plain old penicillin or cefazolin is going to be sufficient to treat you effectively. Now, CMS says that's not an appropriately broad, either of those is not appropriately broad spectrum. And so what we've done is we've built a regimen where we say, okay, Ancef plus vancomycin is your empiric therapy. We're going to still get you on the right drug. We feel very confident, but we're also making sure we're meeting the measure. 48 hours in, 24 hours in, we can de-escalate, but we're still making sure we're regulatory compliant and clinically compliant with our order sets and how we devise them. And so some of the logistical concerns, obviously, because all these are so time sensitive and they're critical, what we've attempted to do to really limit, at least on my side, on the pharmacy side, time to antibiotic, is we develop those order sets with empiric choices, right? So there's less hunting and pecking around what do I want to treat, what do I need to pick, so that it's there at the provider's fingertip. And it's not optimized, but we are working on it. We do ongoing education. This is an example of this. Our pharmacists call with every first dose antibiotic for septic patients down to the RN, the bedside RN, so that they know, hey, something's coming in the tube, go check so you can get it. And what we're really working hard on currently, haven't actually implemented yet, but working on, is taking as many of those antibiotics on our order set as possible, where the standard first dose might be a 30-minute infusion, and using IV push in its place. So instead of 30 minutes, we only got 1 line, we're waiting for sequential administration of 2 antibiotics that are necessary to appropriately cover the patient. We're working on making sure we get upfront access quicker, so at least 2 peripheral lines, or 3 if necessary. We're making that phone call earlier about getting more invasive vascular access. But then we're also saying, okay, even if you only have the 1 line, and now I can push cefepime over 5 minutes instead of 30 minutes, and I can hang my vancomycin or whatever, right? That's going to decrease the time to appropriate antibiotic. Not sure why we haven't thought about this before, but we're looking at taking all the antibiotics that we would otherwise make stat in our pharmacy and then send to the ED, and actually batch them and put them in our Pyxis machines and stock them in the place where the patient needs the antibiotics. So there's less nurses running around calling pharmacy and pharmacy saying I sent it, and somebody being helpful picked it up and took it to another patient's room or put it in their pocket or whatever. We're trying to get it where the patient needs it. And then to facilitate, we're sort of revising how we're doing vanc dosing, using some fixed dosing, and then sort of picking up the back end, just to facilitate faster administration, less decision making, the minutia that doesn't need to be quibbled about in the moment. So yeah, so that's how we've attempted to tackle sepsis from an antibiotic perspective, and we're continually looking to improve and evolve. Any questions?
One question, Kevin. I read something just very recently, and I'm not gonna remember the details, but hopefully you'll know about this. It was something with, I believe, community-acquired pneumonia and some sort of urine sensitivity, that sounded like it was, kind of to give some additional information about sensitivities.
It might be, I mean, the only thing I can think of off the top of my head would be the urinary antigens for strep pneumo or Legionella.
They certainly didn't bring those out, but it was, kind of a brief little article. I'll have to try to find it and send it to you, because I was curious if we do that to help determine, because it made it sound like it might go into the biogram or something.
The only thing I'm remotely familiar with that sounds like that would be, there are some micro platforms that can do direct from sampling identification of organisms using PCR and DNA. And there's some that can screen for resistance markers direct from the sample. Most still require culture of the organism. So other than those other biomarkers for pneumo and Legionella, not.
Okay. I'll try to find it.
I'll take a look too, that sounds.
Okay.
We built in some time for there to be more discussion. So I really am wondering what kinds of questions you have around antibiotics. I know that in your facilities, you probably don't have anybody who's specific to infection control. So this would be a good time to get some of those questions answered by Kevin. I know that there's a couple of pharmacists here, or even just some of the ideas that you maybe have done already to solve antibiotic, giving immediate doses of antibiotic and getting blood cultures done in your own organizations that you could maybe share with one another while we're waiting on lunch.
I'll also just offer that I'm just going to go somewhere else and talk about antibiotics and infection stuff. So I'm always happy to talk about it. So.
We did have a couple hands over here.
Do you have a policy about those antibiotics that have the small volume and then flushing it through the tubing so that they get the full amount?
So the question is, did everybody hear the question? So the question was about, do we have a policy for antibiotics that are administered in a small volume and flushing the tubing set after administration? So no, it's a very astute question. Oh, sorry.
Actually, we do. For nursing, and we just started like 2 days ago with our pump reconciliation. So we made sure with our pump integration, we made sure that that was in there and that there are possibilities in the order sets to take care of that, that the TKO line would be increased to the same rate that the antibiotic was in for a dose of up to like 50 cc's to cover that tubing. So it's kind of in our procedure and in our order sets. Because that doesn't
That solves a huge problem.
Brand new.
And if we're dosing with syringe pumps, the antibiotics, then after we infuse it, we flush the med through the line, we infuse the antibiotic on the syringe pump, and then we load it with a saline syringe and flush the 0.4 through that syringe. So yeah, we have different procedures to make sure that whole dose gets in the smaller population, pediatric and neonatal.
Well, in real time, let me say that's amazing because we went through this at another institution I was at because it does absolutely, the residual drug in the line, especially when you're doing prolonged infusion in like a 20 ml set, does result in reduced pharmacodynamic target attainment. So we went through an entire process devoted to fixing that at a previous institution. So to find out that nursing has already solved my problem was
Well,
amazing.
the pharmacy was involved as well.
It was a group project.
Yeah.
Oh, sorry.
No, I was gonna say one more question over there as well.
Yes, questions about like, do you have a sepsis code page? And do you have pharmacists that respond to that code?
So, no, we do not have pharmacists that respond to any sepsis code or page. I'll kind of defer to adding Denise on the remainder of that question.
We do not have a sepsis alert. Our alerts are all within our emergency department, and we don't have one specific to sepsis at this time. It's an idea that keeps presenting itself, and Candy can elaborate, but in-house, our sepsis alert is actually our rapid response team. And so it's for any patient who's deteriorating. We do have our rapid response team order set, that if the patient meets criteria for sepsis, and we expect them to do a sepsis screen as part of their complete head-to-toe assessment, that they can order the lactate and the blood cultures from that order set, so that we've got it started. Then when we call the provider, we can say, we've already done this and this, can we start talking about antibiotics or whatever else? Is there anything to add, Candy, on that, on the bird team?
No, but we have that order set, we can do it, initiate it, and then call the provider, do the screen, get the lactate, ABG's lactate, get the blood cultures drawn, and then call the physician, so we don't have a delay.
I think this is a good opportunity as well, that a new thing that we just started in the end of May is what we call the Deterioration Detection Center. So that is kind of a new thing even across the United States, where we have a room with an ICU nurse with multiple monitors. And one of those things on the monitors that they do look at is a sepsis score, or a sepsis predictive score. So what they do is, in the event that we have a patient that is scoring high with that predictive score, they go in and do a clinical review of the chart. And since they're active ICU nurses, they have a very good kind of a regimen that they go through, looking through for different pieces of evidence. If there is a piece that is missing, or we have overlooked, or it appears that maybe we thought the patient was improving and now they're spiking back up again, we haven't done another repeat lactate, those sorts of things, they go ahead and call the nurse, and they talk about that back and forth, and maybe there was a very good reason why they didn't do it, maybe it is, they're actively ordering it now, but that Deterioration Detection Center has been another initiative kind of looking for kind of what you're talking about there, where it's not an alert that you hear overhead, but more a one-to-one conversation that this detection center nurse would then have with that floor nurse to say, hey, have we considered this? Maybe we should call the provider about this, or I am really concerned, maybe we should actually call the BERT team and get some more resources to that patient.
And how often that you would do the sepsis score review?
So the sepsis, the system does it automatically for us, and it recalculates and looks for new data in the chart every 15 minutes. So it is very real time, but again, that also depends on nurses documenting that in the record. So if we have, somebody that's holding some vital signs in their pocket, or, a head-to-toe assessment that's still right here, those are going to delay our ability to recognize maybe what's going on with the patient. But that is something new that we are very excited about. It's definitely more up and coming across the United States now that we're looking at it a little bit more. But another way that we have actively, reached out to try to help everybody on every unit with identifying sepsis early. Because as we've talked about, and as Dr. Burton talked about it as well, it's very tricky to recognize. So unless you have 5 or 10 minutes to kind of put the pieces and parts together, which this individual does, since they don't have, doctors tapping on their shoulder, or they don't have call lights going off, they're able to dig into that chart and find all those parts and pieces. So very exciting as well. Yeah.
Is that similar to like an EICU?
So we kind of consider it kind of a midway point. So we've heard other places where they have implemented something where these deterioration scores or sepsis scores populate, and it's really dependent upon the nurse to kind of look at the score and then look into the chart. Where in EICU, they might have video cameras and monitors that they can actually like zoom in on the patient, or they can talk to the patient, or they can take a blood pressure cuff from this center. So we're kind of right in the middle, so it's not quite an EICU, we can't see the patient. We don't have any rhythm strips that we are actively able to monitor. It really is these every 15-minute scores, and then really kind of digging into the chart to find where we might have an opportunity to interact.
So is that what triggers someone to show up in that?
Those scores.
Mhm.
Okay. It's the predictive analytics that runs in the background that kind of through the evidence-based practice that EPIC has provided as well to kind of show those different scores. Yeah.
So Abby, what specific score out of EPIC are you using? What's scored into there's LACE scores and there's a
is there
So
one?
it's a mixture. It is not just one tool. So our sepsis specifically looks at 17 different factors. So those include the SIRS criteria. It also looks at mental status documentation, also looks at some of your lab results that you have coming back or what's ordered. Whereas the deterioration overall score actually looks at 79 different factors in the system. So who here has the ability, what's that? Did I flip it? Did I say it wrong? Sorry, deterioration. Deterioration is the 17, sorry, sepsis is the 79. So yeah, so who has time to go look at all of those factors and really come up with putting all those pieces together? So it's very valuable to then have it do it for us and pop up every 15 minutes and automatically refresh so we can evaluate what's going on.
But we are finding that, I mean, it's still very new, but those are tools to really trigger that person with the experience and the critical thinking to really look at it and start to ask more questions, so.
One more over here.
Switching gears just a little bit,
Yeah.
which medications are you using now for extended infusion?
Yeah, so our policy right now just has Zosyn as our standard. We are in the process of facilitating the build to get cefepime and meropenem also built as prolonged infusions as standard, since those are the three really workhorse beta-lactams that we have at the institution, and places where we most often recommend for sepsis or septic shock. So we want to make sure we're dose optimizing in the most vulnerable patient population first.
Kevin, I have a question about the longer infusion. So is there any research behind, like, if you're wanting to do longer infusions for each drug, like better outcomes, is there any research behind making sure then basically they would have an antibiotic running 24/7? So we wouldn't give the Zosyn and Vaco together, like you would time it after the infusion so that they're getting something all the time, or?
Yeah, so it matters a little bit on which drug we're talking about. So as you go from penicillins to, or as you go from carbapenems to penicillins to cephalosporins, the amount of free time above MIC you need becomes higher. And so you can really, any intermittent infusing or anything other than a continuous infusion of a beta-lactam is sort of a practical solution to the problem, which is to have 100% free time above MIC for that patient. And so it's not absolutely necessary for every antibiotic, because different antibiotics have different pharmacokinetic properties. But for a lot of them, if we really wanted to take to the next level, we would have continuous infusion as I'm covering 100% of the things that I could possibly cover with this drug, because I can then achieve a higher and higher free time of MIC for MICs that are, technically resistant. So really, even the prolonged infusion is sort of a logistic compromise between ideal state and what's practical and feasible. And so we really attempted to do it where it needs to be done, and where it's most likely to benefit. And in some cases, we have deployed a continuous infusion because the organism, they required this antibiotic, and the organism had an elevated MIC that we couldn't treat, with using even a prolonged infusion. So, but yeah, there is clinical data to support improved outcomes with using these dose optimizing strategies. Certainly.
Okay, well, thank you very much, Kevin, and